So good morning, everyone, to the second exciting day of International Diabetes Expert Conclave. From today, we have our signature EBM masterclass, which we thought was the time demanding thing of experts in the field from all over the country coming up and having the discussion on important topics, which can at the end take a very important message, which can be directly translated into clinical practice. And for the very first session, we have none other than the stalwart Dr. Usha Sriram ma'am, who is an endocrinologist and general physician in ADIA, Chennai. I am sure the audience is very well versed with who and what Dr. Usha ma'am is doing for last 38 years. So she'll be leading this first session, which is a very important session and practically very difficult and a lot of question raising topic, that is diabetes and obesity, the care during the preconception time. So I request Dr. Usha ma'am to briefly introduce her experts and take over to the session. Over to you, Usha ma'am.
Thank you so much. Okay, one second. Thank you so much, Anjali. And I must thank Neeta and the entire organizing team, Sanjay and you and everyone for putting this topic as an important part of the EBM masterclass because it's so vital. And I'm so honored to have Professor Sarita Bajaj, Professor Mala Dharmalingam, and Professor Sunil Gupta as my co-panelists. And Sarita is consultant endocrinologist, former director and head of medicine, MLN Medical College, president of the RSSDI, and she has held many important posts. And the RSSDI established Professor Sarita Bajaj oration in RSSDI UP in 2018. Gotten many awards, an amazing speaker and teacher. So I'm thrilled to have Sarita on board. The next person will be Dr. Professor Mala Dharmalingam. Mala is a dear friend for many years, director and the Bangalore Endocrinology and Diabetes Research Center, senior professor and HOD of the MS Ramaya Medical College. And again, Mala is great interest in many areas in endocrinology, particularly in thyroid and PCOS and many women's health areas. So welcome, Mala. And Dr. Sunil Gupta, freshly minted president of DIPSI, is a diabetologist, CEO and MD of Sunil's Diabetes Care and Research Center from Nagpur. Again, very well published, has many honors and awards through the years, and has been a national treasurer for the RSSDI in 2019 is the national treasurer for RSSDI from 2019 till 2022, and is the DIPSI president. So really honored to have all three of you as the panelists. So today's session is on preconception care of diabetes and obesity. And what I thought was just set the stage because each of the speakers will be addressing different areas. Like, for example, Dr. Sarita will be talking about diabetes and pre-diabetes. Mala will be talking about obesity, and Sunil will be talking about prevention of GDM. So I really wanted to just very quickly set the stage that particularly in this post-COVID era, talking about women's reproduction and women's health is very vital because all these things, non-communicable diseases, maternal, child health, everything has taken a backseat and has been deprioritized thanks to COVID. And all the human resources and other resources have all been channeled towards that. So I'm very glad that we are addressing this. Traditionally, we have been very myopic when it comes to maternal health because we only have been looking at it as healthy mother goes on to have a healthy baby. But we know that you suddenly overnight cannot become a healthy mother. It has to be a paradigm shift where it has to be healthy girls have to become healthy women who then become healthy moms who can have healthy babies. So we need to go back and start making sure that preconception care really happens from the time of childhood and adolescence as well. And why is it important for preconception care? First, more than 50% of pregnancies are unplanned. And when we say planned, we really are not talking about any preconception care, but really make that the woman is expecting to get pregnant. That's all. That's all is the planning. So even in that 50% are unplanned. Health of the women currently of reproductive age, 15 to 49. And by the way, just to tell you, in India alone, there are more than 300 million women in the reproductive age group. So their health is not good like before. And with good preconception care, birth defects can be minimized, and I'll show you. And maternal health influences fetal health and growth. Baby weight can be optimized with preconception care. And now we also know that pregnancy is a window to future chronic disease. So if a woman has an uncomplicated pregnancy, chances of her developing chronic disease in the future goes down. So the first 8 weeks are so critical that if preconception care is not there and she walks into the pregnancy, the window is already closed. You can get all kinds of birth defects and complications simply because of lack of preconception care. And women think they are too young for diabetes or pre-diabetes. The CAR study has clearly shown the interrupted blue lines are young women, as you can see. Young women are having so much pre-diabetes in Chennai, in Karachi, in Delhi, everywhere, that these are all the people who are walking into their pregnancy. And does preconception matter in diabetes? Clearly, it has been shown preconception care, so many preterm births avoided, 3,000 birth defects prevented, perinatal death. So we know it works and it should be done. But to me, really what is very important is if you take good care of the mother, the baby will not develop diabetes. If the mother doesn't get GDM, baby does not get GDM. So both a multi-generational and transgenerational impact will not be there. And in a snapshot, I just want to say maternal diabetes means offspring diabetes early on, recurrent GDM, future cardiovascular disease, offspring obesity, visceral adiposity. All these challenges we knew. I just want to add one more, which is now they are linking diabetes in pregnancy to lung health of the offspring. And COPD, we know, is also an NCD, which is why next week, and Sunil is part of that, we are doing a program on gestational diabetes as the mother of all NCDs, because it's leading to all these problems. What about obesity? You can see in most of the states, the women are more obese, and maternal obesity can lead to increased placental growth and big babies, or it can cause maternal hypertension, gestational hypertension, and problems with the placenta, vasculopathy, and actually have SGA babies. And this big study that is going on called, Top Moms, and the top stands for Towards Prepared Moms. That's what it stands for. The Top Moms program, they are looking at women and studying, because you can see obesity in the mother can lead to so many problems across the life course, and the woman herself in future developing many complications. So obesity in the mother leads to multiple complications. So what solutions can we offer? And I think that is what Sarita and Mala and Sunil are going to talk, mention to us about what we are seeing in the ground level and what solutions. But I just want to say that the 4 simple steps to preconception care that we should be following is a dialogue regarding the patient's readiness for pregnancy with all women who are just married, planning to get married, in the process of getting married, or planning a pregnancy in the next 1 year. And a big low-hanging fruit, which we forget, is between pregnancies. So postpartum care of the woman is actually preconception care for the next pregnancy. It's really important to not miss these women and not think only of preconception care as first babies. An evaluation of her overall health and opportunities for improving her health and education about the other things, social, environmental, occupational, behavioral, all that should be discussed. And very, very importantly, which is what we'll be discussing, is identification of women at high risk for adverse pregnancy outcomes and address all of these things. So on that note, I will stop and invite Sarita to talk about diabetes and pre-diabetes.
Thank you, Usha. That is, I think you've set the stage very, very nicely. And my role is set already. Again, I would like to thank Neeta, Sanjay, and Anjali for organizing this wonderful meeting. And like Vijay said right in the very beginning, I think the idea here is brilliant. Okay? Visible? Audible?
Audible, yes. Visible also. Yes.
Right. So what I thought is that I would just focus on diabetes and pre-diabetes, like it says, in young women and women of reproductive age. What is the relevance? And of course, a lot of prevalence data will be there, ending up with what you just gave, those 4 salient points. I will focus on a little bit, because I think that's more of Sunil's task to go into the details of prevention of gestational diabetes. So I'll be focusing a little on the guideline aspect as well, what we should be doing. So this is the roadmap that I will be taking. Undoubtedly, amongst the top non-communicable diseases in women, both, you can see diabetes and cardiovascular disease are right on top. And we know that women with diabetes have so much more to manage. I'll be discussing a little bit about the morbidity, the mortality. You can see the percentage of diabetic deaths, 9th leading cause of death in women globally. And we are all aware of the fact there's so much more of heart disease, as well as the microvascular complications. In the South Asian women, in Indian women, I'll be talking about the neglected aspect of diabetes as well. So we have the global prevalence data.
I think there's some connectivity issue. Sarita's.
Yeah.
Neeta, shall we jump to Mala and then come back to Sarita?
Yeah, we can do that. But I think Sarita was in a rush or something to go to college.
Correct.
But yes,
Correct.
as you said, let's move on.
Or shall we? You want to give her a call, or
we'll give her a call in the meantime, and I think Mala can start her presentation. Yeah.
So I'll just share my screen.
Yeah, except Sarita may have to unshare her screen.
That will happen automatically.
Okay, sure.
So my screen is visible?
Yeah.
So thank you very much. Thank you, Usha, for the introduction. And thank you, Neeta, Anjali, and the whole team of IDEC for having invited me. So today I'm going to talk for the next 7 minutes. That's what Dr. Usha has given us to talk about reproductive age group. Hopefully 7 minutes. Please pardon me if it becomes a little more. So basically, this was a study which was published in the lower socioeconomic countries and developing countries, just to show between 2002 to 2012 how the mean BMI has gradually increased in women of the reproductive age group. You can see it is almost going up vertically, almost to reach roughly around 60% in 45 to 49 years, and also in the age where they become pregnant between 25 to 35 also, the prevalence is almost up to 40%. Now, if you look at different BMIs, at whichever age group you take, the BMI which is more than 30, they are the largest among all the population of women, whether they are normal weight or BMI of 25 to 30 or more than 30, we find that it is quite a significant increase, almost about 16 to 20% of people are more than 30. Again, this is again the global data. Now coming closer to India, this was another very elegant study which was published only in 2020, looking at low and middle income countries. So it's like a twin of underweight as well as overweight. Here you can see India in the underweight, and we are quite high in prevalence of underweight. This is also very important. It's not just obesity, but even if you see underweight, we are almost right at the bottom, which means that 40% of our population is underweight in women. And if you look at obesity in women also, we are quite close at about 20 to 25% of overweight and obese. So it's something that India has to tackle, that we are also looking at underweight women who are also going to go into pregnancy, and overweight women who are becoming pregnant and causing problems. Today, let's talk just about the obesity part. Again, this is looking forecasting what will happen in 2040. If you look at all the BMI ages of 20 to 34 or 35 to 54 or 55 to 69, let's look at 20 to 34 alone, because that is the age they become pregnant. If you look at 2010, the point estimate was 8%, and at 2040, the point estimate will be 15.6. This is for overweight rural, obese 1.7 and 5. So it is all increasing, whether we are looking at overweight or obesity, or whether we are looking at rural or urban. Closer home, urban, you have 2010, overweight is 17.4% is the point estimate, and it will become 25.1% by 2040. And in obese is 5.4 to 9.9. This is something which we cannot afford to increase, and we need to look at it. Now, this is again same forecasting, overweight, rural, urban, put in a nutshell. You can see that in all, whether it's rural or urban or the national, we have a increasing trend, and it is estimated that overweight will from 14.7 will increase to 27.4%, and obesity, which is at 4.4%, will increase to 14%. And closer home, I have Karnataka data, which shows that normal weight is about 63%, overweight is 23.8%, and obesity is about 12.7% of women in the reproductive age group in Karnataka. So now the problem is just not obesity. It's called osteosarcopenic obesity. What happens here? There's osteoporosis, like how Dr. Usha and Sarita were saying. There is bone loss and there is muscle loss, but there is increased adiposity general as well as abdominal adiposity, which causes fat infiltration and fat redistribution, which is called osteosarcopenic obesity, which is very increasing concern in India, because India as such has very poor muscle mass. Now, the risk of it, apart from the general risk, the risk of women, why do they suffer? Social environmental pressures to be thin, teasing history, discrimination, reaction to their weight by family, and this is called weight cycling. If you see here, they go on one diet, they lose weight, then they put on weight, then they go on the second diet. This is called cycling. They go up and down. And this itself has been found not only to affect them mentally, but also cause an independent risk. So they go into binge eating and hunger, cognitive factors. These are something which is very important, because this is the age group that they have image satisfaction, and they have hugely body image dissatisfaction. So it has also been seen, the less educated, the more obesity. Here you can see no education or primary education, the obesity is maximum compared to the higher. And this is again a data for showing in Indian women frequency of TV watching. If you see here, I've just taken this part out, where it says if you see almost every day, it is about 13.9 relative risk more. And if you don't see, the risk is about, or percentage is about 4.6%. So almost 4 times the risk if you see TV every day for obesity. This is the body image. This is a standard Stunkard scale where the person, how they feel about themselves when they put on weight. And this is how it is. They are graded from 1 to 9. And if they put on weight, their self-image becomes less and less. And anxiety, depression, whether you're looking at anxiety scores or depression scores, it is quite high. So these are all some problems. Long-term arterial hypertension, diabetes, anemia, depression. This is 30 people who had a bariatric surgery who were morbidly obese and 30 people who did not have. And you can see that once they lost weight after bariatric surgery, all of their parameters came down quite significantly. And this is just to say that obesity can cause, the traditional risk factors are hypertension, dyslipidemia, diabetes, and gestational diabetes, preeclampsia, premature delivery, and endothelial dysfunction are some of the problems. But apart from that, long-term ischemic heart disease, heart failure with preserved ejection fraction, peripheral artery disease, obstructive sleep apnea, all are problems of obesity. So something we need to deal with. And this is again data to show CV mortality. As the BMI increases, the CVD mortality increases, and so does any death, cause of death of any cause, that is also increasing with increasing BMI. This was another Europe data which came out in women, the hazards ratio by BMI. And as your BMI increased, whether it's MI, ischemic stroke, CVD death, or death from any cause, kept increasing. This was a very interesting article from European Journal of Preventive Cardiology in 2020. So how to deal with it? Very difficult question. And it's a very interesting topic. I'm sure we can debate on it. Of course, we need to do exercise training, hypocaloric diet, and in that period of time, whether they need hormone replacement or vitamin D. These are some of the speculations, but I'm sure we could discuss when we have the question answers. But yes, and of course, a lot of counseling. I feel that is very, very important when we are talking about obesity, especially in the reproductive age group, and of course, a lot of support. I'll end here and over to Usha once again.
Thank you. Thank you, Mala. So I have a couple of questions, and the questions were for Sarita and for Sunil, but we are all welcome to jump in. And so Sunil, if you want to take, I had 2 questions. One was, one was to Sarita, which was, should schools and colleges and workplaces, incentivize healthy living or a healthy lifestyle? Otherwise, how are we going to motivate young people to get healthy? So that's, Sunil, you want to take that question? Yeah.
Yes, thank you very much. And again, congratulations to the whole team of IDEC and Dr. Neeta and Sanjay and Anjali. Thank you. And thank you, Usha madam, for introducing so nicely to me. Now, the question is, intentionally, we have not prepared any slide, but maybe it is, I thought it should be more of a discussion. I'll put more into the practical aspect of prevention, and then we'll put myself into how does the education can help. I feel all 3 speakers have wonderfully kept the platform ready for discussion. Importantly, we know the prevalence, we know the outcomes, we know that obesity is bad, we know everything. Now, our focus today is on preconception care. So one thing is very important, our delegates should know. That's unfortunately, it is the mismatch. We have 3 important issues. One, that we have a transition in the culture. Earlier, when I was born, my mother was possibly got married at the age of 16, and possibly when I was born, it was around 17 or 18, something on those lines. Many of us who were born, our mothers were of the age below 25. And most of the childbearing issue used to be over in our Indian culture, or most of the culture across the globe, before 25. But because of the career issue, we have our own data of GDM around 900 pregnancies. I just want to share it's unpublished data. We say that the average age of GDM in this part of the country is 29.5 years. So average age of marriage has gone up, average age of conception has gone up, and unfortunately, the age of diabetes is coming down. Earlier, we used to see patients with diabetes that after 50s and near 60s. But now we are all getting a data coming from AIMS with Nikhil Tandon group. It says I feel 30% of the patients are being diagnosed at a very tender age of less than 30 years of age. So we now have young diabetics being detected. Reason we know all about the overweight, obesity, dietary habits, physical inactivity. I feel everyone has said this. So we have a mismatch of young people coming to you, young women coming to you with either pre-diabetes or diabetes or polycystic ovarian syndrome. And then they are also getting conceived at a later age. And this again becomes an additional risk factors. If they want to plan their pregnancy, they should try to finish up by before 25. But unfortunately, that is a cultural change which we have to accept it. So what is important is that how should we address this issue and how should we go ahead? The thing is that education becomes a pioneer here. Education, and education. That's the main part of it. And every speaker has said this, that more and more you counsel, you have to possibly first is detect them early, maybe in a pre-diabetic stage, maybe in the hyperinsulinic stage, maybe polycystic ovarian disease. So if we have to first detect them early, catch them young. Now, madam has just spoken about the colleges. I'll say in the schools, let us focus on the middle and the high school children and adolescent education. I feel that again is an important challenge, that they should be preventing their obesity from the early stage, because we know almost 70 to 80% of the children who are obese in the childhood, they ultimately remain obese adult. And the prevention of obesity in the childhood should not be only, there is no data available from the pharmacotherapy point of view. There is no recommendation. So we have only one thing, and that is lifestyle modification, dietary interventions, and physical activity, which need to be improved and in the society. So diet plays a major role. We are not going into detail of it, but we have a data coming out from the DPP trial, Diabetes Prevention Program trial. Of course, that was a program amongst those women. There's a subset of women who had past history of GDM and then becoming diabetic in the later part of life. And we have found that almost 57% of the women could prevent the development of diabetes with those who had past history of GDM, and they could be preventing the development of diabetes after GDM if they are on lifestyle modification, and also if they're on metformin therapy, and they responded well to metformin. But here our data, our discussion is the conceptually that can be picked up, that we lifestyle modification does prevent, and more you make the society aware of it. Possibly, Usha madam, will be able to target this. We have seen the risk factors. I was just listening to Mala madam. We have seen the risk factor. We know TV watching is bad. We know physical inactivity. Children don't have a place for the outdoor games. So we need to encourage and see to it how best we can counsel them and pick them young. If you pick them young, if you pick them early, I feel the compliance is going to be more. And of course, someone coming to you with a very, very early, and when it comes to preconception, then I feel in the preconception phase, we know that the data says 90% of the women, they have an accidental pregnancy. And this is what is even true for women with pre-diabetes as well as diabetes. And this accidental pregnancy may create a problem too when women comes to you with maybe 10 weeks or 12 weeks of pregnancy, when the organogenesis is already over. They're already on the drugs which are contraindicated for during pregnancy, and then we are in trouble, and then we have to all have so such situation, if we don't want to see your face, I feel we'll have to have more and more education and awareness in the society. Every woman coming to you with childbearing age, even at the age of 40, should be given a counseling, that's preconception counseling. Every doctor, every clinician should tell them that you can become conceived. You should take conception issue only after the counseling or permission. So unless and until Dr. Usha Sriram or Mala madam or Sarita madam or Niglur sir tells you that you are fit for pregnancy, you should not be planning your pregnancy. Every childbearing, and we have seen people coming at the age of 43 and 44 also with second or third child. Similarly, those who had past history of GDM, when they plan for second pregnancy, even they have to be warned for it. They should be screened for it. Annual screening, I feel we know the rule of 6. After delivery, they are supposed to screen themselves at 6 days, 6 weeks, 6 months, and then once in a year for diabetes. And then they should be counseled. But unfortunate part is the postnatal care in our country is very, very poor. Patient goes away from us as well as possibly from the gynecologist, and they'll end up with pediatrician. So I feel now some action. I feel Usha madam will have to focus the pediatrician also. There should have been someone in the pediatrician group coming in as a panelist here, should be discussing with us that how can, because every woman will land with the child for the vaccination to a pediatrician. And that in that phase, I feel we should be focusing on screening and education of these women, and they land up with the pediatrician. So something on these lines maybe there. Of course, the weight reduction, other things will further be discussed. I feel I have done little, taken more than 7 minutes, if I'm not wrong. Usha madam, over to you.
No problem. Thank you, Sunil. Sarita is back. So Sarita, can you jump in and wrap up your part of it, and then we can have a quick discussion on the various aspects.
Yeah, so I think, can you tell me till where I was?
You were on this one.
This one?
Yeah.
Right. So this growing problem is going to be the highest in India. And there's data from the ICMR INDIAB group, and that is for young women with diabetes and pre-diabetes. As you can see, the graph is going up. Of course, there's again data from India, metabolic syndrome, all across north, south, east, and west, from 10.7 to a whopping almost 46%. The risk factors which are relevant, women-centric. Number 1, PCOS, a history of gestational diabetes, and parental history of gestational diabetes as well. Then, of course, this is from our neighboring countries, type 2 diabetes in women from about 7.4 to 8.9%. This is our own data. This is about almost 40,000 school children whom we studied, looking at obesity as well as abdominal obesity. It was more in women, especially the prevalence of abdominal obesity. It was significantly higher in girls, in metros, in private schools. So this is the shape of India today. From what was being done earlier, this was the best gym once upon a time. And I think Mala, I'm sure, has already elaborated on this from what I heard from Sunil's discussion. And this is the current scenario. As far as I said, I'll be focusing on South Asia as well as India, the problems that are unique to us. The risk for diabetes is many-fold higher. The diabetes-related mortality is higher. I'm talking of an age range from 20 plus. And this is all across. This is all across the globe. The mortality is higher for women as compared to men. There is definitely anxiety which is associated with type 2 diabetes. We have data from Delhi that mental health among diabetic women living in New Delhi was much higher. Sexual health concerns are never discussed. Malignancy, again, there is a very, very strong association with colorectal cancer as well as sex-specific malignancies of the ovary and endometrium. Now, the malnourished mother. So this is, see, what we are walking here is a very tight rope. We're talking of obesity, but what about malnourished? So malnourished, poorly cared for girls, when they become mothers, they'll have small footed babies, more of metabolic syndrome, obesity, type 2 diabetes, a poorer brain development, poorer decision making, and more of complications. And women constitute more than half of the South Asian adult illiterates. We have scant economic resources, delay in seeking care, gender discrimination, social taboo. So, and definitely males have better access. Look at this. When we talk of availability of insulin, again, girls do not get a preference. These are the challenges which Sunil has highlighted: lack of preconception care. Usha has referred to that. Again, child marriage, yes, it's still existing. The medical complications, problems from the society and family, all these need to be addressed. And of course, the crowding, the lack of privacy in overcrowded healthcare facilities. What are the fears of young girls? If they have diabetes, they'll not be accepted. How will they bear the cost of the treatment? Fear of being rejected by the husband and in-laws. And then the worry of not being able to have a healthy pregnancy and a healthy baby. Again, I've already addressed PCOS, the stigma, the body issues, the anger and the self-pity about not being normal like other girls. In this context, from RSST, I was very happy to have this publication. Thank you. Thank you to RSSTI for that. And the solution, we are obviously wanting some solution. Usha also referred to this, but it starts with healthy babies, healthy girls, healthy women who will become healthy mothers in turn. And good health begins with good preconception care. Sunil just said that 99% of pregnancies are unplanned. It should not be that way. A little bit about preconception care. It's a crucial and sensitive time, described as a continuum of care designed to meet the needs of women throughout their reproductive life. So it should be comprehensive. There is evidence-based practice, and it is associated with major reductions in adverse pregnancy outcomes. So this is reproductive life plan, from counseling to risk assessment before pregnancy occurs, medical decision making, and a collaborative approach. You need a lot of team members to collaborate with, and all have a very important role to play. The whole aim is to reduce the number of unintended pregnancies and maximize health before conception to improve pregnancy outcomes. So we're talking of women, young women, and women of the reproductive age as well, whether it's type 1 or type 2. So the risk assessment, you would look into the biochemical parameters, you would look into the complications, you would assess the maternal social deprivation, unplanned pregnancy, and then yes, we know women are taking alcohol and smoking in any form. Then preconception visits and a thyroid function test is extremely important. So you need to set targets, better glycemic control, monitoring for progression of retinopathy, nephropathy, and changing any prior medications. So what do the guidelines tell us? So this is for women with pre-gestational diabetes. We need a checkup, we need a counseling, we need A1C, the dosage of folic acid and the timing, an ocular assessment, a renal assessment. If there is reduced GFR, a nephrology consultation, blood pressure, medications need to be looked into, and screening for coronary artery disease as well. Then look at what about the statins, thyroid function testing I've referred to, weight reduction. If they're overweight or obese, weight management is very important. Then for women who have had gestational diabetes, the follow-up, the postpartum testing is mandatory, and then a routine checkup every 1 to 3 years, and lifestyle counseling to prevent type 2 diabetes after gestational diabetes. And where to catch them? I think Sunil has rightly said, yes, when they go with their babies for the vaccination. So if you educate a man, you educate just a man. If you educate a woman, you educate a generation. And women are the real architects of society. And like Dr. Ambedkar said, that I measure the progress of a community by the degree of progress that women have achieved. So it's a challenge. There are many special concerns. Mala rightly said, yes, promote physical activity. Nutrition counseling should be individual, a comprehensive care program, and CV risk reduction. We need to be very aggressive. And remember, for women, diabetes is usually well below the family. So the family comes first for most women, and be the healthcare partner and the advocate. Thank you. Thank you very much.
Thank you, Sarita. I think what we'll do is dive right. We only have about 4 minutes left. Dive right into a discussion. I'm just also looking to see if there are any questions in the chat box. I don't see any questions. Neeta, do you have any questions that have come in?
No, there aren't, but I would like to ask you to actually, supposing there came a woman who actually came for preconception care, what would be the algorithm, or what would be the quick points that we need to look at to make her pregnancy ready?
So in general,
in terms
or
of
someone
diabetes,
with diabetes
and obesity? Yeah.
Oh, so I think Sarita has outlined it, but I'll just crystallize it, just saying first is we have to stop the medications that are not approved. For example, statins and ACE and ARBs and certain OHAs, I mean all OHAs, and switch to insulin and the insulins that are allowed. And then, of course, get a baseline A1C and green light the pregnancy only if the A1Cs, I would say at least below 6.5, even though ADA and others say 7. But that we'll also have to individualize a bit, because if they have other complications, you may want to look at 7. But otherwise, I would look at 6.5. And now, cardio obstetrics has become the emerging big field, because it's not, heart complications of women who get pregnant is now become the biggest complication. And also for the babies, fetal echocardiogram is needed. So making sure that there are no cardiac complications, especially in type 1s and long-standing, type 2s. And as Sarita said, check out the thyroid and educate the women about self-monitoring of glucose, set the targets, and start a fetal surveillance with everything from anomaly scan to fetal echo to the quadruple testing. I mean, the whole process goes on. And later on, very importantly, of course, and that's into pregnancy already, but in preconception, it's making all these changes and getting her ready, in a nutshell.
Yeah, can I, Neeta, we also can add the screening of other vasculopathies pre-existing. So if someone has diabetic retinopathy, we'll have to warn them that it may get, there can be progression of diabetic retinopathy. Those who already have proteinuria in overt diabetic nephropathy, there can be a risk of progression. You also have to look into now cardiomyopathy and associated macroangiopathy, what Dr. Mala has already said. So I feel, and Dr. Sarita Madam has said, so I feel we'll have to also assess the micro as well as macroangiopathy, which might get further exaggerated. And there are some strict contraindication. Our delegates should know what is the contraindication for pregnancy to a person with diabetes. If someone has autonomic gastroparesis, someone has EGFR very low, some patient with CKD, patient with cardiomyopathy, I feel there should be even that should be told to people.
Yeah.
So I would like to add, the folic acid is extremely important.
Yes.
And apart from the checkup for the micro and the macrovascular complications, including retinopathy, I think that progresses enormously during pregnancy. So that must be kept in check. The statins we have to stop. And a lot of the women, of course, we know may be on statins. And the weight reduction, because that oodles of weight that they're going to add on in pregnancy and the postpartum period. if we are going to prevent subsequently type 2 diabetes, and we know that gestational diabetes is a form of frustration of type 2 diabetes. I think all these points are extremely important.
Usha, there is a question from Dr. Robin Maskey from Nepal who has logged in, who has said, an excellent talk, ma'am. And what about screening of fundus in GDM and how frequently you do the screening?
Short answer, we don't do screening for GDM. It's only for pre-gestational so, but if I diagnose GDM early in pregnancy, right, then it's possibly someone at first booking, for example, it's probably someone who's walked in with undiagnosed pre-diabetes. And we know that in pre-diabetes itself, you can have, retinopathy. So, getting a fundus exam then makes sense, but there's no official recommendation.
Yeah, we have, I think, one more minute.
Nita, we can also add to this that possibly he's asking for pre-gestational diabetes also, but by mistake he's written GDM. Yeah. But we should also tell them that if the person has no retinopathy before conception, then there is no risk of development of retinopathy due to pregnancy. No microangiopathy is likely to start because of pregnancy. It is only pre-existing microangiopathy which will progress. That is one important thing. But if someone has, say, mild to moderate NPDR and some in such situation, then they can even go for laser therapy during pregnancy. Laser photocoagulation is not contraindicated during pregnancy. That is another message. But if someone has PDR, proliferative diabetic retinopathy, it is one of the relative contraindication for pregnancy.
Yeah.
No, I think, Sunil, I would like to add that the basic thing is how frequently. So during pregnancy, like Usha, even if it is gestational, these lines are very overlapping. So yes, even in gestational, I would get a screening first time as soon as it's diagnosed, and then every trimester. So I would look into it every trimester. So at least three times it should be looked into. And of course, if there is, like Sunil is saying, then we have to have an ophthalmologist on board to look into the management part.
One last quick question to the expert panels. If a woman is obese when she comes to you for preconception care, would you ask her to defer pregnancy until she has lost some weight?
I was just going to say that, see, I am very worried about obesity in preconception for several reasons, not just the fact that they may have trouble conceiving or gestational hypertension or GDM, but also we are learning a lot about autism spectrum disorders and ADHD and neurocognitive defects and, serious problems with even babies subsequently. So we don't want to medicalize pregnancy. We don't want to scare anyone or anything, but I think gently we have to help this person defer pregnancy for 6 months to 1 year. I mean, it's a luxury if they come for preconception care. And that is going to be my mission for 2022, to make preconception care a specialty.
Right.
Yeah, but Usha, see, that won't it depend on the age of the woman who's coming to you. If she's already coming at that cusp where pregnancy is going to become more and more difficult, I would any day want her to get it over with and then look at, because 6 months to a year may be, like very crucial window. And I'm sure women are marrying late, trying to conceive late. I think the age would be very important.
No, I agree, but I'm just saying that those are, exceptions. But majority, most of them, I think, must see they are anemic. They may not fully vaccinated. Their nutritional deficiencies. They may have mental health issues. They may have other things that we need to address. They may be taking medications that they are not supposed to over the counter or prescription medicines. So there's a lot of stuff that needs to be, or bugs to be, removed and fixed before they can walk into that pregnancy. And if we can popularize this, evangelize this concept, I think this will catch on, just like women are taking folic acid now routinely. So making it popular like that.
Thank you very much,
if everything else is in order, then obesity should not be a deterrent. If everything else, like you're saying, all that other aspect is managed, but she has not lost weight, or maybe gained a couple of grams, milligrams, kilograms, then I would still advise her to please have a baby and then move move on.
Thank you. Thank you very much. Very reluctantly, I'm having to close this session. I think the masterclass has shown up more, thrown up more questions than answers, but that's how the subject is. And thank you all very much for joining us this morning. It's been a wonderful masterclass.